All right, I think I'm going to start because you'll want me to get through my slides first before we have our discussion with Carol. So I first want to welcome you all to our first event in our Women's Brain Health virtual conference series. As you know, we're in the middle of a pandemic, so we had to, I've called it reimagined because we had to reimagine this event. Before I really sincerely begin, well, good thing I did this. My slides are not advancing. There we go. I would like to acknowledge that we're hosting this event on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And we do thank them for allowing us to host this event here. So as you know, we were supposed to meet in person in May, but because of the pandemic, we had to change the series. Instead of holding a virtual conference over a couple of days, we thought that we'd host one every month because I wrote in my notes, because every month is Women's Health Month, or it should be. Every month should be Women's Health Month. So please take a look at our website. You'll see that we have a number of symposia, workshops, networking, and some special presentations from some, I'm going to call them women's health media gurus, Patricia Thomasay and Shirley Weir. That's coming up pretty soon. Also, we can do this without our sponsors, so a big thanks to Michael Smith Foundation for Health Research and CIHR, Canadian Institute for Health Research, as well as Elizabeth Rideout, who received a CIHR Sex and Gender Chair and has generously donated to the cluster so we could hold these events, and Elsevier, which is a publishing company. So this is put on by the Women's Health Cluster. We're a multidisciplinary collaborative network of women's health researchers and stakeholders. We have over 150 members right now across the world. And you can look on our website. We have blogs, this conference, and we also have a free women's health seminar series. It's not just focused on the brain, but all aspects of women's health. And it's free to join, so please, if you're interested in becoming a member, please it's as easy as sending us an email. So we invite everyone along. And the reason we have this is because the reason why we have a cluster in the first place is because there's so few studies that are done on females only, lots more on males only, both in animals and rodents, but also in human and animals, very low percentage. So we want to spotlight that we also need work done on females and women. So for our agenda, we're kind of halfway through. We're almost done the welcome already, and then we'll start the discussion with Dr. Carol Tavris, co-author of Estrogen Matters. And then for slides and questions, we've made it so that you can't ask questions. So you'll have to do this electronically using Slido. Just put it in Google, just the word Slido, and it will come up. And you'll need that conference code 13999 to ask questions. And if you would like to engage on social media, there's a Twitter hashtag WBH2020. Again, there's a Slido website, and the event code is 13999. Feel free to tag us on Twitter and Facebook, and please feel free to join us. And of course, a little, if you feel like supporting our initiative, there's ways that you can do this in a tax beneficial way. So I'm going to stop sharing my screen now and welcome Dr. Carol Tavris to our first event. So thank you so much for doing this. Carol is a social psychologist, writer, and lecturer who has spent her career bringing good psychological science to the public, and we need much more of that. She describes this as an uphill challenge, no doubt. And she has placed an emphasis on gender, culture, critical, and scientific thinking. And we really need a lot of this these days. I love this too. She describes herself as a feminist since childhood, thanks to her egalitarian parents, and a mother who earned her law degree at the age of 21 in 1927. Isn't that incredible? Also, when I was looking through the list of her authored publications, I had to chuckle to myself, and it made me realize how much I already identified with her. So her books are titled, one is titled Anger, the other is The Mismeasure of Women. She has another co-authored book called Mistakes Were Made, but Not by Me, which explains why all of us are so often find it hard to admit we were wrong. there's some pretty famous examples right now too. She also writes a column for a skeptic magazine called The Gadfly, which pretty much sums up all the work she's done in her life. And when I personally read Estrogen Matters, which is the book that Carol co-authored with Dr. Avram Blooming, I was just stunned by the amount of wealth of research, the deep dive that you brought to bear on the subject that many of us thought was long resolved by the Women's Health Initiative, namely that, estrogens are bad and dangerous for you. It's a cogent, comprehensive book, well laid out. At the end of every chapter, there's a take-home message, which I really appreciate. I ask my own students to do that when they give talks. And sprinkled, there are examples from women's questions to Avram throughout his practice, and some good humor throughout as well. It's clear, it's beautifully written, and I highly recommend it to anyone that's interested in hormone replacement therapy. Indeed, I loved it so much, and it resonated with me. Just look how much I bookmarked my own copy.
Oh, you're the ideal reader, Lisa.
That's right. Anyway, and I'll just tell you, each of those bookmarks was a time that something that they wrote surprised me or made me laugh. That was another reason I wrote it. I bookmarked it. So, Carol, my first question to you is, what led you to write Estrogen Matters with Dr. Avram Blooming?
Well, I've known Avram for a very long time, since the early 90s, and we have long shared a love of science, even when the science is ready to question an established paradigm. I started kidding him, saying, I'm going to call you Don Quixote. And he said, well, in that case, you're my Sancho Panza. You're coming with me on this. Because what I would do in psychology, in bringing important psychological science to bear on people's personal and social issues, that's what Avram was doing in medicine. Avram always followed the evidence wherever it might lead. And for many years, he had begun to question the establishment paradigm that estrogen causes breast cancer. And in his own practice as an oncologist, hematologist, he received permission from the FDA to do a study of giving hormone therapy to his patients who had had breast cancer. So I want to say at the beginning, when we say, why did we write this book? I want to say one important reason that one non-reason. Neither of us is a subsidiary of any pharmaceutical company. When Robert Wilson wrote his book on Feminine Forever, he was a subsidiary of the pharmaceutical industry, and it was a scandalous and appalling and patronizing, awful book. Neither Avram and I have taken a dime from Big Pharma, and that has not been our motive in writing this book. And moreover, for me, I never had a personal vested interest in hormone therapy. I, like my mother, sailed through menopause with nary a symptom. And so I never really appreciated what menopausal symptoms can mean and how many millions of women really have an awful time in menopause. And it's not just for a couple of months or a year or something either. So when I was a young feminist, it was easy to sort of be snide about menopause and the idea of hormones in menopause. Like many feminists, I thought it was sexist and ageist, and what is this idea of hormone replacement anyway? Replacement? What an insulting word, What, the female body is gas tank? Just have to fill it up? It felt, I shared the feminist view, the concern about pathologizing the normal changes of a woman's life, and had written a lot about that. Things happen, we go through them, quit thinking of them as illnesses to be treated, okay? So for me, I'm going along, not caring terribly much about estrogen one way or another, when the Women's Health Initiative appears. And Avram calls me the second the press release is released to the public saying, Carol, this is just scandalous. The National Institutes of Health was stopping the study because of the increased risk of invasive breast cancer, coronary heart disease, stroke, and pulmonary embolisms. Since that press release, since that frightening finding contradicted 50 years of research, I've said, get out your burro, Tavris. Quixote and Sancho are on the warpath. So we began writing about it. We wrote a few medical articles for medical journals, about the problems we saw in the Women's Health Initiative, that it was fine to have those accepted, but they weren't reaching the two biggest audiences we cared about. Physicians who needed to know what was wrong with this massive study, and women who need this information so much in order to make informed decisions about what they want to do about hormones. So we thought, you know what, we're going to put this all together in this book, see what we can do.
Well, I'm so glad that you did.
Thank you.
As a scientist, it never ceases to amaze me how many people interpret data wrong. I mean, and we see this even now in our political and scientific lives, I would say. And I always tell my own students, you know, you really need to pay attention to the methods and the results. You know, people will say whatever they want to say and they'll have a wonderful, gorgeous title, but, you know, are their claims really substantiated? And are the authors interpreting the results appropriately? And you and Avram eloquently outline that this is really pretty much the major fault of this Women's Health Initiative study and its published reports. So you can obviously see why I couldn't wait to bring you here. So can you tell us a little bit about the Women's Health Initiative and outline a few of the more outlandish claims that they made?
Oh, yes, I thought you'd never ask. Women's Health Initiative, first of all, you have to understand, this was such a huge thing. It cost nearly $1 billion. There were 40 principal investigators who were the top scientists, physicians, epidemiologists, statisticians in the country. It was really impressive. And the first paper came out in JAMA, the flagship journal of the American Medical Association. And it was so alarming. It increased risk of breast cancer and all these horrible things. So no wonder women panicked. Prescriptions for HRT plummeted, really plummeted. Oh, I want to say this little postscript about the hormone replacement idea, by the way. When I was first thinking critically about hormone replacement, I thought that estrogen diminished slowly and modestly the way testosterone diminishes slowly and modestly in men. But it's not, it's a plummet. Estrogen plummets to about 1% of what it was before menopause. And so we aren't talking about something subtle, we're talking about a major change. I just wanted to make that clear. So the Women's Health Initiative lands with this massive splash, and immediately it became the guideline for anybody working in this area. This was the go-to study to cite. It took a long time before one of the insiders of the Women's Health Initiative, Robert Langer, actually published a paper on what was wrong from the very beginning of that study. And it's so important. I want to tell you what he wrote here. It says, highly unusual circumstances prevailed when the Women's Health Initiative trial was stopped prematurely. Highly unusual is understatement. The investigators most capable of correcting the critical misinterpretations of the data were actively excluded from participating and disseminating the information. 3 of those 40 eminent people wrote the paper, and the rest did not even see the paper in time to make any corrections because it was printed in the warehouse and ready to be shipped. Now that is just beyond disgraceful, yeah?
Right.
The other thing, once that article finally came out so that physicians could look at it, was they saw this was not the ideal healthy sample of menopausal women. 70% of these women were highly overweight or obese. Nearly half were past or current cigarette smokers. More than a third had high blood pressure. And although the findings were supposed to apply to all menopausal women, the sample had a mean age of 63. Only 10% were between 50 and 54. But they never had any compunctions about saying, oh, this applies to all menopausal women. And I would say the most damning aspect was that although the Women's Health Initiative investigators said, we are completely impartial and unbiased. Actually, if anything, we expect to find that hormone replacement is a wonderful, beneficial thing for women. 6 years before those findings were published, the lead investigator, Jacques Roussel, published an article in which he called for an end to the HRT bandwagon. So there's too much estrogen being prescribed here. This is not a good thing. It's time to halt the bandwagon. This is a guy in charge of assessing whether the bandwagon is healthy for women. So that was what really shocked us so much about the discrepancy between how the Women's Health Initiative was portrayed to the public and what they were finding. Now, I know you have a couple of favorite examples of how they went back into their data, twisted them around to get scary results. Would you like to offer your favorite one?
Wow, I mean, there's so many, so it's hard as like picking your favorite child. You can't pick one, but I had to, because Carol said we don't have all night to discuss this. So darn it. But yeah, so I guess probably because I'm a neuroscientist, the one that really struck with me was that HRT, or hormone replacement therapy, doubles the risk of dementia. I kind of, I knew some of the problems with the study in the first place, but not all of them. I had not, I guess I sort of swept the bad news under the rug and didn't really want to think about it anymore. But I just want to read you one of my favorite parts here, which is dealing with this particular incidence. First of all, it doubled the risk, but it went from, I think, 1% to 1.8%. I don't know if Carol would be talking about that. So it's a really small percentage. But worse yet, I'd say, ERT and HRT, they reported, were indeed associated with cognitive impairments, but only among women who were already cognitively impaired at the onset. So when women who had mild cognitive impairment, which is sort of a prodromal state to Alzheimer's disease, at the start of the study were excluded from the analysis, the results were no longer statistically significant. And then they go on to describe a little bit more, but then what I love for the readers is you have translation. The cognitively healthy woman on HRT did not become cognitively impaired. But the headline is, it doubles the risk for dementia.
That's the headline. See, that is the kind of thing. I tell you, this is quite a fascinating thing to, if you have basic trust in researchers and their publication, you tend not to look very critically at the data.
Yeah.
But once you see the problems, that the findings about breast cancer were not statistically significant, I don't know about you, but when I was a graduate student, that didn't get us a publication.
Yeah.
Well, the editor of the journal would say, "Go home, honey."
Especially to JAMA.
Do that.
Come on.
Yeah. So, I mean, well, one of my very favorite ones was the menopause findings. Okay. So in 2003, the Women's Health Initiative issued a finding that made headlines everywhere. The headlines were that estrogen does not have a, quote, clinically meaningful effect on health-related quality of life during menopause, even among women who had been taking it for 3 years. So once women who'd been on HRT during menopause stopped laughing, they said, what are you talking about? Okay, here's how they got this finding. It's quite amazing. First, they explicitly discouraged women who reported having moderate or severe symptoms from participating in the sub-analysis. Yeah? So we only end up with 13% who have severe symptoms, and more than 3/4 of them who have been randomized to take HRT report significant relief of symptoms, just as every other study has found. The rest of the women, the 87% who had no symptoms or minimal symptoms, reported no relief of symptoms.
Shocking.
Shocking. I looked at Avram and said, wait, the women who didn't have symptoms reported that estrogen did not relieve the symptoms they didn't have. Yeah, that's what they're saying. Yeah.
Yeah, sorry about that. That was my cat. So, of course, the beauty of being online. So as I've already shown everyone, there are a lot of shocking statistics in the book that I bookmark each time something surprised me. And what really also surprised me is I think of myself as a researcher that studies the effects of estrogens on brain health. So if it was shocking and surprising to me, of course it's going to be, well, I was shocked at my own lack of knowledge about how much I had taken for granted what the WHI found as truth. And as you mentioned, the studies really shocked our world by suggesting that hormone replacement therapy increased the risk for breast cancer. So can you set the record straight for us? What exactly is our risk of getting breast cancer if we take HRT?
Oh, I'm very happy to answer that one. And I want to say one thing, by the way, about the process of writing this book. Our interest, our goal, was not to take one study that contradicts the Women's Health Initiative, or just for that matter to debunk the Women's Health Initiative. The way we have to understand the risks and benefits of any intervention for women is we have to look at the whole picture as best we can, the mosaic of studies. And that is something we really tried to do. And where we found outlier studies that did not support what we think was going on, we did a really careful, close analysis of them. Right. So with that said, let's look at breast cancer. I love this.
I love it too.
The table I'm about to show you, I had gone to see Avram give a lecture on risks, different factors involved in risks of breast cancer. And this table so blew me away. I was completely knocked out by this. So he knows I go nowhere without this table now. Okay. Here we have a relative risk, and I'm sure you understand about relative risks. If the risk is 1, it's neither beneficial nor harmful. If it's less than 1, it's actually slightly beneficial. Keep this in mind, this estrogen only Women's Health Initiative. Fish intake has a 14% increased risk of breast cancer, which is, I think you will agree, not very important. Premarin progestin, so HRT, Women's Health Initiative in 2003, a 24% increased risk. HRT 2002, this was the study that stopped the presses, the press conference, the yelling and crying, okay? 1.26, it was not statistically significant. And the following year when they reanalyzed it, even any modest trend toward significance had vanished. Having an extra serving of French fries a week in childhood, 27% increased risk.
Don't take away my French fries.
I am. Grapefruit a day. We're getting up there, huh? Night shift work, 1.51. Being a Finnish flight attendant, placental weight. Antibiotic use for more than 1,000 days, although it actually depends on what you're using it for. Apparently antibiotics know what they're being used for before they increase your risk of breast cancer. Left-handedness, being an Icelandic flight attendant. So you can see already that if you are an Icelandic left-handed flight attendant who likes grapefruit and French fries, you are at some risk. What I want to point out here is that these findings all found homes in medical journals without attended press conferences and panic, okay? And with good reason. They were spurious, they're trivial, and they're medically meaningless. Electric bedding. How did we get a finding about the risk of breast cancer from electric bedding? Here's how. We do a study of 304 African-American women with breast cancer, comparing them to women without breast cancer. The increased relative risk, most pronounced for more than 10 years of use. Does anybody understand that? More than 10 years of use, but only when women who used the device for more than 6 months a year were excluded. This is called data mining, and it is a no-no in science. What data mining means is we expect a finding. Does bedding increase the risk of breast cancer? We don't get a result. We get no result. And we say, instead of saying, hey, good news, it doesn't cause breast cancer, we go back into the data and try to find a pony in there. That is not acceptable scientific and statistical procedure, and yet it is done over and over and over again in many of these epidemiological studies. Here is a finding that means something about the risk factor A and the disease outcome B, tobacco and lung cancer. That's a finding that really matters.
I'd argue with that one.
So here's what else we review in the book, the symptoms of menopause. I had no idea how many of these were symptoms of menopause. Most women don't know this either. And so as a result, they go to rheumatologists for joint pains. They go to psychotherapists for depression. They go to sex therapists for painful sexual intercourse. They go to therapists for other emotional things. You know, I mean, they go to specialist doctors rather than seeing this whole package of possible symptoms, many of which begin in perimenopause and then continue through menopause. And these aren't trivial. Years and years of not sleeping wreaks its own health risks. The average duration of symptoms is nearly 7.5 years. Estrogen lowers the frequency and severity of symptoms by 80 to 95%, and no other treatment comes close. Heart. This is one of the most surprising findings for women. Throughout life, a woman is 7 to 8 times more likely to die of heart disease than of breast cancer. Women are terrified of breast cancer, but heart disease is a far greater risk for women. In fact, after 40, a woman's risk of dying from heart disease is greater than her risk of dying from breast cancer. Which is, I think, such a powerful finding. And in fact, now that so many more women are surviving breast cancer and breast cancer treatment, they are in greater risk sometimes of developing heart disease. We now have a new specialty, cardio-oncology, that's designed to help women who have been treated for breast cancer avoid the next great risk of heart disease. And look at this. We've known this for decades, that it decreases the risk of heart disease by 40 to 50%. Osteoporotic hip fracture. Well, I didn't know this either. As many women die each year after an osteoporotic hip fracture as from breast cancer. Calcium and vitamin D, sorry, sorry, they do not decrease the risk of fractures. Long-term HRT is more effective in preventing femoral fractures than bisphosphonates, which have their own side effects and far more risks than estrogen. And even the Women's Health Initiative acknowledges that estrogen is probably the best thing to do for women at risk of osteoporosis. And as you were saying, Liisa, brain and cognition. Alzheimer's is such a killer and horrible disease, and studies of the benefits of estrogen on the brain, from laboratory animals to human beings, from field studies to experimental studies, find an unmistakable benefit of estrogen on brain function. Barbara Sherwin, whom I'm sure many of you may know, who was at McGill for many years studying cognition and estrogen, was so adamant about this. She said, you know, I know women who think that it's not natural for women to take estrogen after menopause. She said, what's not natural is living 30 years after menopause. And so, as a result of these benefits of hormones on heart, brain, osteoporosis, many decision analysis reviews from the 1990s to the present have concluded that if women begin HRT and stay on it, that should increase their life expectancy for up to 3 or 4 years. Look at this amazing study from Batur using National Cancer Institute findings. The cancer-related mortality rate for invasive breast cancer was 17.9% for non-users and 4.5% for women on HRT. And Roger Lobo in 2017, summarizing all the data to date, likewise concluded that women on HRT have a 20 to 40% reduction in overall mortality rates. The Women's Health Initiative, which began by saying, no, taking HRT increases a woman's chances of death from all causes, they have stopped saying that. So what is the Women's Health Initiative's current view of HRT and breast cancer? This is one of my favorite slides, and it's actually since the book was published, so you're getting some news here. The Women's Health Initiative today agrees that estrogen on its own is safe. So women who have had hysterectomies are able to take estrogen on its own, and not only is it safe, it reduces breast cancer risk and mortality. But is that a national press conference that we're going to say this? No, because they still want women to worry that it's the combination with progesterone that's risky. And then Hodis and Sorrell discovered this on a closer look at the studies the Women's Health Initiative has used of women on HRT. The women on HRT had a slightly elevated risk of breast cancer that was statistically non-significant. Okay, but it's a slightly elevated risk. Should we worry? It turned out that the elevated risk was not due to more incidences of breast cancer in the women on HRT. It was due to a decreased, unexpectedly low breast cancer rate in the control group. That's weird. Why did the control group women have a lower breast cancer rate? Because many of them had been on estrogen before the study began. And for the women on HRT, compared to placebo, the breast cancer rate was not affected for up to 11 years of follow-up. I'm still waiting for the Women's Health Initiative to call a press conference to reassure women that HRT is not deadly. One of the investigators actually said in an interview, well, it's okay actually for women now to use vaginal creams with estrogen for their sex lives. That's completely safe, that's fine. And then one couple wrote to a therapist friend of mine saying, the therapist friend had recommended, using vaginal estrogen. And they said, we opened the box and we see a black box warning. Do not use, you're gonna have an increased risk of dementia, heart attack, stroke, and breast cancer if you use this cream. And they looked at each other and said, we'll forego sex, if those are the risks. So, there you have it. That black box warning is still associated with every estrogen product. Okay, end of slideshow.
Thank you so much, Carol. There you go. There you go. You're back.
There we go. I'm back.
Okay. Well, yeah, it's stunning, really, right? When you lay everything out, and that's what I think you do so well in the book. It becomes stunning and hard to understand, shocking, hard to understand why this has been so persuasive. So the other thing, as you already mentioned, we know that when these studies came out, it greatly decreased the HRT prescription rate. And then first we were told, don't take it. And I know my mom was going through this at the time, and she was heartbroken. And then it was the lowest dose possible for the shortest amounts of time. Oh, yeah. So in your research, is there any evidence that to take HRT for short periods of time?
Okay, that advice represents a compromise.
Right.
It's, what do we say? A camel is a horse designed by a committee or something. What's that question? I can't remember. But it's a compromise between this. We've told you that HRT is dangerous, but we actually know that it helps a lot of women. So how are we going to resolve this? Okay, I have an idea. If you must use it, just use a little for a short time. There's no evidence for this. There is no evidence for that advice at all. It just represents this compromise that lets everybody breathe more easily. The North American Menopause Society actually in 2017 issued a position paper on this, in which they concluded, get this, the concept of the lowest dose for the shortest time may be inadequate or even harmful for some women. There are no data to support routine discontinuation of HRT for women age 65 years. And by the way, especially for osteoporosis, because while HRT is the one greatest benefit for strong bones for women in later years, as soon as women stop taking HRT, their bones will revert to the same degree of fragility that they had at the outset. So in the case of osteoporosis, it really is a lifetime thing to take for women who are at risk. This statement of the North American Menopause Society has been endorsed by 31 menopause societies around the world.
Wow.
From China, Taiwan, Italy, Israel.
Canada?
Canada! Oh yes, Canada.
Yay!
Several societies in Canada and Australia and England. Yes. So it's a very powerful statement because.
But that doesn't seem to make the media as much as the original, sort of sticks in our mind, right? So, why do you think why do you think that the media, physicians in general, and the general public have held on to these erroneous conclusions for so long? So why, I wrote in my notes, why in 2020, 18 years after the first publication in JAMA, are we still battling these incorrect, misleading claims?
Lisa, I have spent my entire life as a social scientist saying to people, here's some really interesting evidence that will require you to change your mind about everything you believed about this. You want to listen to me, or you want to tell me where to go now? Okay, so there's a number of reasons for this. The Women's Health Initiative is very powerful, very eminent. There are now, I'm happy to report, in the last 10 years particularly, many more physicians, gynecologists especially. Gynecologists were more doubtful about the Women's Health Initiative than oncologists and other specialties. I think because they see in their practice women doing well on HRT. My own gynecologist, when our book came out, he put it on his desk. He said, I don't let a woman leave my office without taking a picture of the cover. So many doctors are aware of the flaws of the Women's Health Initiative, and there's beginning to be a change in that regard. But once you have establishment thinking that has made its way into guidelines for doctors who don't have time to do the research themselves, all they're going to do, what am I supposed to do with this patient here who's got symptoms? Oh, don't give her HRT, give her something else. That's what they're going to do. Look, in the same way we've known for years and years that low-fat diets are not the answer to obesity. Decades of low-fat diets, and the low-fat diet industry, it hasn't said, I guess we're wrong. Let us change our minds immediately, right? So once a belief has become an established way of thinking, it's like a battleship in a creek. Mm-hmm. It's really hard to turn it around.
Right.
But it's the other main reason Avram and I wrote this book, and we wrote it in a way we hoped that, most menopause books can be very helpful and useful to women, or cheerful and pep talky and so forth, but we wanted women to have the evidence so they can go to their doctors and say, hey, look what it says here about breast cancer. Look what it says here about osteoporosis. With every study clearly listed, along with readable takeaways for readers who aren't interested in the data themselves. So that's one thing. But it's, it's your interest and our interest is in what's best for women, and what it takes nowadays for all of us as individuals. We have to all become our own best experts, don't we? Yeah. Or at least to know what the alternatives are. Avram said to me once, he said, look, a pregnant woman has 10 times the amount of circulating estrogen as a man. And many women, if they develop breast cancer during a pregnancy, were advised to abort the pregnancy. Okay? Doesn't a woman need to know that getting breast cancer while you're pregnant does not affect your prognosis, not at any stage of your breast cancer? That it's not relevant? Go ahead and have that baby? How about women with the BRCA gene, who many of them have their ovaries removed and their breasts removed, and immediately have terrifically difficult menopausal symptoms? Don't they need to know that they can add back estrogen and not increase their risk of cancer? You know, these are, how about women on in vitro fertilization, which likewise increases their levels of estrogen. If estrogen were causing cancer, don't use IVF if you want to get pregnant. Wrong, wrong. So, you know, it's time to turn that battleship. And I think the more information we can get to the public, to women who are willing to say to their doctors, we got to talk about this. That's our hope.
Yeah, I mean, I have a couple more questions that I have here, but and I know there's lots that are coming up on Slido, but I do want to ask the two remaining ones that I have. So, but I'll try to ask this one quickly, because I'm certain that it's affecting some of the people that are on this call, and that is, and actually you spend a chapter, Avron talks about a very frustrating experience with the FDA, the Food and Drug Administration, and trying to get a study, you know, approved. And I've definitely run into this bias myself as a researcher, and very recently. So in it finally got funded, but the last iteration of it, one of the reviewers said, well, why would we give hormone replacement therapy to females, because we know it's bad for them. So even it's been so pervasive in so many, you know, not just to the public but to researchers as well. And we need more studies. We don't need fewer studies. We need, you saw that data at the very beginning. We have so few studies on females. So I mean, you talked a little bit about this. How do we flip that conversation and get the public and clinicians and funders to realize that HRT benefits health? It's just, and it's necessary and important field to fund. Any advice on that?
Any advice other than read our book? Well,
yes, exactly.
The advice. Some physicians and researchers, as you well know, are open to disconfirming evidence. That's what science, by the way, is all about. Is willing to consider that we could be wrong, right? And others, you won't change their minds, you know, with a sledgehammer. You can bang on their heads and they're going to not change their minds at all. And Avram has had many, has written to many eminent physicians, some who he's known disagree with him, and I have also. I wrote to the Women's Health Network, a feminist organization that thinks HRT is an ageist and sexist thing to do. And I said, could you just read our book and tell us where we're wrong?
Right.
Tell us where we're wrong. We want to know. And basically you don't get replies. And Avram, who is so open-minded about these things, is always puzzled. Why aren't they responding? And I have to explain, because, you know, once you believe something, you're not interested in reading a book that's going to tell you that you're wrong. So there are a whole lot of people who aren't going to change their minds. And then there are people who will. So I see this as a long challenge, in the same way that if we, you know, to change our view about that fat is not the culprit in our diets, but sugar is more likely to be the culprit. How many years and years did Gary Taubes have to write his books with the most persuasive evidence there could be to make a dent? So the task is in education, in publishing, in protesting, in writing, and in disputing when you encounter a physician or a researcher or somebody who takes it for granted that the Women's Health Initiative is the 10 Commandments. You say, you know what? There's been some really interesting research that's suggesting maybe not so much. That, you know, that we just take every opportunity where we think there is somebody with an open mind.
Yeah, you'd hope that, you know, as a physician, as a GP or a gynecologist, if you come armed with evidence, you know, that they'll listen to that evidence.
Well, you know, Avram was instrumental when he first moved from New York to California to overturn the practice of radical mastectomy. At the time, radical mastectomies were based on the view that breast cancer travels contiguously. So if you have it in a breast, you have to remove the breast and everything around it. And it was a logical theory. It was a widely held belief, and it was wrong.
Right.
And so what Avram did was organize an interdisciplinary consortium of physicians across many specialties to consider the evidence that lumpectomies were as safe and effective, and certainly not as disfiguring as lumpectomies. But if you were a surgeon who had made your living on doing radical mastectomies and believed that you were saving your patients' lives, they weren't doing radical mastectomies because they were bad doctors, but precisely because they thought they were saving their
They're doing the right thing.
So changing a belief is, especially in medicine, well, not especially in any field.
And anything.
In
I'm
any
thinking about politics.
yeah, no,
Let's not go there. It's hard.
The more there's a groundswell, the better will be. I mean, the Women's Health Initiative itself has walked back virtually all of its early scary findings. It just hasn't done so with a press conference and bells and whistles.
Right. And that herein lies a problem. Okay, we have lots of questions up here. Hopefully we can get to at least a few of them in the last 13 minutes. So I'm going to, the one that has the most votes is great talk, and it was a great talk. What about, but I'm, it's a very specific question. What about the risk of blood clot stroke on HRT? Are there still the same kind of beneficial effects?
Blood clots and stroke. Here's the issue, and actually it's relevant to the number of women who have written to Avram to say, I'm in my 60s, I've not been on hormones, is it safe to start?
Right.
If a woman, so we refer to the menopausal window, the 10 years of the onset of menopause and following. During those 10 years, that is the time when HRT should be begun if a woman's having symptoms and wants to begin taking HRT, because it basically continues the levels of hormones that she's familiar with. After that 10 years, the arteries narrow, and if a woman has any plaque in those arteries, then starting hormones out of the blue can cause some of that plaque to break off and indeed cause a clot. That's where the concern comes from. It's only within the first year of starting HRT, and after that there is no increased risk. So it's clearly interacting what it must be a pre-existing condition of plaque in the arteries,
right,
to be a greater risk.
Well, that makes sense, and I know in the literature we sometimes refer to that as that critical window.
Yeah,
that's when hormones can really be the most effective, and it makes sense.
A letter from a woman in her 80s. Can I start now? No.
So there's a bunch of questions about, can you use bioidentical hormones? Safer, or is it the same thing? Or
all right, here's the other thing. In the our concern, bioidenticals, if it's a marketing term, bioidentical. See, how can something be identical and not the same, or the same but not identical? I never remember which it is. It was basically designed to reassure women that you can take estrogen in a different form, and it's not really estrogen, only it is really estrogen, so you'll have the benefits of estrogen. Bioidenticals are safe, but our concern is compounded bioidenticals. That's where the danger and risk are, because those are unregulated and who knows what the hell is in them. And there have been a number of really damning summaries of the risks of the compounded bioidenticals. And let me add to that, that stepping into the vacuum of the many women having menopausal symptoms and not getting relief from their doctors, there's now a big business booming of how we can treat you and help you and make you feel better on a concierge basis. Let me help you with black cohosh, and here's this other thing, and a chaste tree, and who knows what it is. None of those are beneficial. And the argument that I'm going to tailor make your bioidentical hormones to use specially, this is a promise without any data evidence or really validity. And with that said, let me just say our website for the book has every update we could find that's relevant to any of these issues of our book, including bioidenticals and a statement, a consensus panel discussion on bioidenticals. So I would encourage people to look at the website, and from there they can contact Avram about anything medical that they might want to ask.
Sure. Yes, because there's also questions about, well, I was going to say before, you'd think that there'd be a lot of studies out there on estrogens, and there are many different kinds of estrogens. There aren't that many, right? We just talked about how sort of the political fallout has been fewer studies there.
Well, then let me add one thing about that. One of the people ask Avram all the time is, what about this kind of estrogen or that kind of estrogen? And
right.
he's usually said, I hope I'm representing him correctly, but he'll basically, estrogen, fine. But Premarin, the original, the first version ever, has several kinds of estrogen, including echinacea, which is the one ingredient relevant to cognitive function.
Yeah.
So if you've got a choice, you might want to consider that.
And I was just going to say that there are, very fewer studies, I would imagine fewer studies on the bioidentical. So, we don't know enough, I would say, about a number of the
it's the compounders that's the worry. Lord knows what compounding pharmacies are doing. They could put sawdust and fly powder in there and you wouldn't know.
Right, exactly. And I don't want to eat sawdust and
no, you don't.
Why? I mean, I think we asked this question already, but why do you think the Women's Health Initiative decided to ignore their own data and conclude without strong evidence that HRT is bad for women? So, is there politics?
This is the great question we get all the time. What were they doing? What were they thinking? Why? And we don't know. We don't know. So the nice reason. I'm just a regular person, not an investigative journalist. The benign reason would be to say, they just believed estrogen was dangerous, and they looked for any sign that it was dangerous. And when they didn't find a sign that it was dangerous, they went back in and dug around until they found a way of finding it was dangerous for women between the ages of 52 and 54 and a half. They really
cherry pick the data.
Yeah. So that's one. Another is they really did have an agenda, implicit or explicit, as Jacques Roussel said, to end the bandwagon. Now, do we know why? Some of the investigators, as cardiologists, believe to this day that statins are better in protecting women from heart disease than estrogen is. But statins are not effective for preventing a first heart attack in women. They don't work on women the way they work on men. They aren't as beneficial for women as they are for men. And they have many more side effects, including liver enzyme disorders than estrogen does. So was there some agenda to move women over to statins, the biggest selling drug in the world, than HRT? I don't know. Maybe and scientists all know this one too. Any scientist who has studied sex differences, if anything, knows you will not get a publication with no differences. We didn't find any difference between men and women. Why, they're exactly the same here on their math and spatial abilities and all around cuteness. Will anyone publish that? No. But if you have a little sexy difference that you could describe, that gets a publication. So maybe the Women's Health Initiative was thinking $1 billion just to say HRT is safe? Really? Are they going to feel we've earned our money? I don't know that either. Please understand, let me make it as clear as I can. I don't know the answers.
Right.
But the fact that they are now, as I say, walking back from their early scare stories, they do it in that passive mistakes were made, but not by us way.
Right.
What a shame that women were so alarmed at the beginning and stopped taking hormone. What a shame that they were, who did the alarming?
Right.
So, yes.
Yeah, it's difficult. It's difficult to know, but that does.
And there were many researchers.
Right. But it sounds like, you talked at the beginning about how they weren't all consulted for that original.
They were not. So one of the primary investigators, Avram, because that's Avram, invited him to come and speak to his fellow physicians at his continuing medical education program at his hospital. So this man comes and speaks and gives his spiel about the dangers of HRT. And one of the doctors stands up afterwards and says, well, I'm just a poor general physician here. Okay. But Avram had already showed that risk table, had already pointed out that none of the WHI findings were statistically significant
Right.
And this physician said, I always understood, with the confidence intervals as bad as you show here and the fact that it wasn't statistically significant, that doesn't seem a very strong finding to me. And this investigator said to this effect, only part of this is exactly right. He said, well, in effect, when you have a study as big and complicated as the Women's Health Initiative, which it was, and you know you will never, ever be able to do it again, and you secretly know that there are a lot of dangers here and we just somehow missed finding them, you ask the statistical police to leave the room.
Oh.
That was his expression. You ask the statistical police to leave the room. Is that a scientific way of assessing your evidence? I just find that so disheartening, so disheartening. So I don't know why they were so determined to find such frightening stories. I do not know.
Yeah, this is I think, good follow-up question here. With so much misinformation, re menopause on the internet, and frankly, I have to say, I had no idea that some of those symptoms that I was experiencing were like perimenopausal.
Yeah, exactly.
So how do we as scientists get women the right information and more education to physicians themselves and public outreach? Like part of this is why I really wanted to start a group like this, but what can we do? How do we get more information? How do we get the right information?
I was just going to say, how do we get good information? How do we?
Yes, exactly. Your website.
Yes. Yes, you put me in a slightly embarrassing position. Well, because we're immensely sympathetic. There's so much junk. And there's so many personal testimonials. First, ignore all personal testimonials. They just tell you what happened for that woman.
Anecdotal, yeah, exactly.
Go and read a funny book about some woman's experience with menopause, but don't take it seriously and don't think it applies to you. But we felt our book was a way of providing that kind of information, along with the criticisms. I want to say that one more time. And I also want to say, we are not doing a feminine forever here. All women must have HRT forever and always and so forth. Yes, there are some risks for some women. Of course, this is not a one-size-fits-all medication for anybody. Our view is that HRT is better for most women, more women than is recognized, and will help many, many more women live longer and healthier lives. And that's been our concern. So what should a woman do? Number one, ignore the testimonials. Number two, look to see what kind of evidence a doctor or a researcher brings. One of the things Avram and I used to say to each other, in psychology, we have what's called the scientist-therapist gap. Many therapists are trained to do psychotherapy, having learned to do therapy from the school of therapy they were taught as grad students or at some weekend seminar. And then you have the scientists who are busy doing research on love and hate and child development and memory and the brain. And very often, therapists are not trained in the findings that psychological scientists have produced. It's not their job, but they say, it's not my job. My job is to help somebody feel better. Yes, but you need to know which therapy is more effective for which problem. Mm-hmm. And Avram would say, you know what, it's very similar in medicine, where we have the practitioners who take what they learned in medical school and go out and do that forever and don't learn much afterwards, why we can keep doing radical mastectomies. And we have the scientists, the physicians who are doing the research. Right. So the fact that a doctor says, I know everything about menopause, well, the doctor may or may not know everything.
Yeah, and I think there's a lot of evidence that even in medical school, they don't get a lot of training.
They don't learn about sex.
No.
They don't learn about, and intimate aspects for women or for men. They're squeamish about many aspects of female sexuality. Don't we all know this? And so, these are topics ignored in medical training. Mm-hmm. So if a woman is looking for information It should be coming from the scientific side of things. There should be a lot of evidence, not just one study. Look at that fish intake study. That's sitting there in the medical journals.
Right.
But it's hard to expect a layperson to say, oh, that's a trivial finding.
Right.
How many replications of fish intake have there been before I decide to cut back?
Yeah, it's the body of work, right? That people, and basically you need people like yourselves to do the in-depth deep dive of all the literature to really sift through the nonsense, and it's hard to expect physicians to do that. I mean, it's hard I can't even keep up with the literature on my own niche area. It's hard. There's a lot of the other thing that people should know, probably lots of people know on the call because we're out of time, but is that there are so many what we call predatory journals, but they're fake news scientific journals. So there are real ones and there are fake ones where people can publish whatever they want for a nominal fee. And so you have to be careful. Even if it looks like it might be from a good source, it might not be. I think there's an article in a free Canadian magazine called The Walrus, and it was called The Rise of Junk Science. And it's a really interesting read. There's questions about testosterone for menopausal symptoms, but I would say it also causes, I think, hair growth. So just, but I think in terms of sex drive, I know there's a researcher named Kim Wallen who's done a lot of research on that. So I'll get people, because 6 people endorse that question. So I just want to get that one quickly in. And there's some other questions, but we're out of time. So I need to, so first of all, thank you so much for this. Thank you for your willingness to reimagine our keynote speech. And thank you so much to you and Avram for this terrific book and taking the time to talk to us today. I'm very glad that you could comprehensively deal with the data and issues. And I really hope that work like this that you've created helps us to spread the truth about HRT and menopause. That would be the dream. And then to everyone else, there's a series. This is our first one. It runs until June every month, because every month is Women's Health Month. And I just encourage you to go to our website and take a look at our series. And thank you so much again, Carol, for your willingness.
You're so very welcome. Great good luck to you all. It's such an important topic, and I love that we got to cover so much. Thank you.
Thank you. Thank you, everyone.